Welcome back. We're going to pick up with the rhythm of the conduction system. So, quick review, we talked about two nodes, the sinoatrial or SA node and the atrioventricular or AV node. The SA node being considered the pacemaker node in that it fires spontaneously at roughly 90 to 100 times per minute. It is the most rapid of the spontaneous depolarizations in the cardiac conduction system. The AV node being located on the right-hand side of the heart between the right atrium and the right ventricle will actually depolarize at roughly 40 to 50 times per minute. So significantly slower, about half as fast as that SA node. We touched on the notion that if both the SA and the AV node fail in their depolarization, if they fail in their ability to generate an action potential, that the ventricular fibers have an ability to do so all by themselves, but that depolarization happens at a much slower rate, at only about 20 to 40 times per minute. So as promised, we need to look at the actual conduction pathway. So remember, we're talking about the electrical pathway. How is the electrical current moving through the myocardium? So you want to know the details of this. You want to know the conduction pathway. You want to know the key players. You want to know the order in which they fire and how that electrical charge is moving across the myocardial fibers through the heart and what the result is. Why are we generating this electrical wave? So we'll start off at number one at the sinoatrial node, or the SA node. It's going to be located in the right atrial wall. So on that in the right atrium, on the right atrial wall, inferior and a little bit lateral to where the superior vena cava dumps into the atrium. The SA nodes cells are unique in that they do not have a stable resting membrane potential. So if you're not remembering resting membrane potential, please go back and review what that means for the generation of an action potential. But these cells do not have a stable resting membrane potential. And what that means for them is that they're going to depolarize spontaneously. They're going to depolarize to threshold and thereby generate an action potential. That spontaneous depolarization is called the pacemaker potential. There's a vocab word, so pacemaker potential. When that pacemaker potential reaches threshold, so here we are in the SA node, when that potential reaches threshold, we're going to generate an action potential. That action potential is going to propagate from the SA node, I've lost my cursor, from the SA node ventrally down through that right atrium. It's also going to cross spontaneously over into the left atrium. So what we're going to see is we're going to see an action potential propagate through both atria simultaneously. It's going to have that ability because of the gap junctions in the intercalated discs, and we're going to move along those muscle fibers. Following, or even rather, if you prefer, the result of that atrial action potential is that both of the atria are going to contract at the same time. So you'll remember that we spoke about considering the heart as an upper and lower pump. So in this instance, we're going to talk about them being an upper pump, and that both atria are going to contract, and we're going to pump that blood from both atria. The right atrium, we're going to push the blood into the right ventricle. The left atrium is going to push the blood into the left ventricle. Okay, and remember that we have this conduction across the interatrial septum because we are still superior to that fibrocartilaginous skeleton, that fibrous skeleton that surrounds the valves. Okay, so as we move from the SA node towards the apex of the heart, that electrical signal, those action potentials, are going to be directed toward the second node, the AV node, or the atrioventricular node. Okay. And one of the functions of the atrioventricular node is to actually slow down that action potential. It's going to actually cause a delay. So we're going to move from 90 to 100 depolarizations per minute down to 40 to 50 depolarizations. And the reason that happens and the reason that's so important for what we're talking about in cardiac circulation is that delay allows time for the atria to fully empty. We're allowing the atria to empty the blood into the ventricles, and there just isn't actually enough time to do so unless we slow down that action potential. From this AV node, all of that action potential is going to enter into what's called the AV bundle, this portion right here, the atrioventricular bundle or the AV bundle, also called the bundle of His, HIS, the bundle of His. The bundle of His then divides. It separates into into the bundle branches. Okay, so we're going to have the right and the left bundle branches that are going to run down through the interventricular septum. Branching off of the bundle of His are the Purkinje fibers, and the Purkinje fibers are going to work to move this action potential back up through the myocardial walls of the ventricles. Okay, an important note about that AV bundle: that AV bundle or that AV node is the only point where we can move an action potential from the atria into the ventricle. We can only do it here at the right atrium. We can only do it through the AV bundle, and that's important because it really directs how these action potentials are going to flow. We don't have to worry about competing or opposing action potentials coming down, one down the right ventricular wall and one down the left ventricular wall, and then having a collision somewhere, down near the apex of the heart. We've got a very directed pathway for this action potentials to propagate and to move. So as that action potential is going to propagate along the AV bundle, and then it's going to enter into those bundle branches, as we've said, it's going to move down that interventricular septum. It's going to round the apex of the heart. We're going to enter into the Purkinje fibers. Those Purkinje fibers are large diameter fibers. They're going to conduct those action potentials very, very, very rapidly from the apex of the heart upward towards the remainder of the ventricular myocardium on the lateral sides. And what's going to happen is those ventricles are going to contract. They're going to contract simultaneously. So the right and the left ventricles will contract simultaneously, just as the left and the right atria contracted simultaneously. And we're going to push that blood up out of the ventricles into the great vessels. So up out of the right ventricle through the pulmonary semilunar valve, and then out of the left ventricle through the aortic semilunar valve.